You know, it's quite startling when you think about it.
Yeah.
Every year, maybe 1 to 5 people out of every 1,000, just in the Western world, they'll experience a blood clot.
It really is surprisingly common.
Yeah, and sometimes our body's own clotting system, it gets a bit overenthusiastic, shall we say.
That's a good way to put it. And this increased tendency for blood to clot more readily than it should, that's exactly what we're diving into today.
Right.
We're exploring hypercoagulable states. You might also hear them called thrombophilias.
Thrombophilia, okay.
Essentially, yeah. Think of it like the body's natural system for keeping blood flowing smoothly is somehow off balance, making clots more likely.
Thrombophilias, it sounds pretty complex.
Can be, yeah.
But we've got a really solid guide for this. We're using information from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition.
Ah, Rutherford's. Good choice.
Yeah, for anyone not familiar, Rutherford's is basically, the go-to reference in vascular medicine.
Yeah.
Super authoritative, really up to date.
Absolutely. It's the gold standard. So you know the information we're discussing today is solid. It's evidence-based.
Right.
Exactly. This isn't just opinion. It's a proper medically recognized overview. Our goal here is really to demystify this topic for you.
Make it accessible.
Yeah, pull out the key bits, maybe some surprising facts, and help you understand why these conditions develop in certain people.
So consider this your sort of fast track to understanding the essentials of why some individuals are more prone to blood clots.
Yeah.
We'll be looking at the root causes, both the kinds you might inherit and the ones that can pop up later in life.
Sounds good.
So let's start with the congenital side of things. What you might be born with.
Okay, congenital, right. So inherited hypercoagulability, it stems from genetic mutations. These mutations affect different parts of the clotting system.
Okay.
And a really useful way to classify them, Crowther and Kelton suggested this framework, is to think about 2 main buckets.
2 buckets.
Yeah, either a loss of natural thrombosis inhibition, basically, losing the brakes, or a gain in procoagulant function, hitting the gas pedal harder.
Loss of brakes, gain of gas.
Got it, pretty much. The first group, loss of inhibition, that involves deficiencies in the body's natural anticoagulants, the substances that normally keep clotting under control.
So the brakes aren't working well.
Exactly. When those are down, the risk of thrombosis goes up. It makes it easier for a clot to form when maybe it shouldn't.
Okay, so let's dig into that loss of inhibition idea first. What are some of these natural inhibitors that could be, deficient?
Well, there are 3 key ones we usually talk about. Antithrombin III, protein C, and protein S.
Okay.
Let's start with antithrombin III, or you might just see AT3. This is a major player in inhibiting thrombin. Thrombin's a really crucial enzyme for clotting, and it also inhibits other clotting factors.
So it's like a master regulator.
Kind of, yeah. So if someone has an AT3 deficiency, their risk of VTE, that's venous thromboembolism, clots in the veins, it's significantly higher.
And how common is this AT3 deficiency? Is it rare?
It's estimated around 1 in 2,000 people in the general population. So not super common, but not vanishingly rare either.
Okay.
But look at people who've actually had a VTE, and that number jumps quite a bit, somewhere between 4% and maybe 7.5%.
No, quite a difference.
Yeah. And it's usually inherited as an autosomal dominant trait, meaning you only need 1 copy of that faulty gene.
Ah, okay.
And there are different types, too. Type I is where the body just doesn't make enough AT3. Type 2, you make enough, but the protein itself doesn't work right.
But the end result is the same. Less clotting control.
Exactly. Less effective braking power.
So if someone has this, what's their actual risk? Like over a lifetime?
It's pretty high. The lifetime risk of getting a VTE for someone with AT3 deficiency is estimated around 60% by the time they hit 60.
60%. That's substantial.
It really is, and it underscores why knowing your family history can be so important. Because of that high risk, if someone's diagnosed, screening their immediate family is usually recommended.
Yeah, that makes total sense. Okay, what about the next one? Protein C deficiency. How does that work?
Protein C is another important anticoagulant. It's vitamin K dependent, like some clotting factors. It gets activated by thrombin, but only when thrombin is bound to another protein on the blood vessel wall called thromboembolism.
Bit of a chain reaction then.
Exactly. Once activated, protein C helps shut down other clotting factors, specifically factors VIII and VIII. So a deficiency here, again, caused by gene mutations, messes up that process.
And how common is protein C deficiency?
A bit more common than AT3 deficiency, maybe 0.2% to 0.5% in the general population. And in VTE patients, perhaps 2.5% to 6%.
Are there different types here too, like with AT3?
Yes, similar idea. Type I mutations mean you have less protein overall, both amount and function. Type 2 means you have normal amounts, but it doesn't function properly, a qualitative defect.
Okay.
What's really striking with protein C is the difference in severity. If you inherit just one faulty gene heterozygous, you typically see VTE, often in the legs.
Right.
But if someone inherits two faulty copies homozygous, it can cause a devastating condition right at birth called neonatal purpura fulminans.
Purpura fulminans.
Yeah, it involves widespread clotting in the tiny blood vessels, the microvasculature. It's a true emergency, needs immediate aggressive treatment.
Wow, that sounds incredibly serious. Okay, and the third one in this group was protein S. Is it similar?
Protein S works hand in hand with protein C. It acts as a cofactor, basically a helper molecule.
A helper.
It boosts activated protein C's ability to inactivate those clotting factors,
Right.
VA and AGA, so it's crucial for that whole anticoagulant pathway.
Got it.
Protein S circulates in two forms. One is free and active. The other is bound to another protein. Deficiency can happen in up to maybe 0.7% of people,
Yeah.
again, due to various genetic mutations.
Let me guess, different types again.
You got it. Type I, less protein, less function. Type 2, normal amount, less function. This one's actually quite rare. And type 3, normal total amount, but less of the free active form because more of it is bound up.
Which are most common.
Types I and 3 are the ones we see most often.
And clinically, does protein S deficiency look like protein C deficiency?
Generally, yes. Patients typically present with VTE. But an interesting point with protein S is that levels can naturally drop during pregnancy.
Oh, really?
Yeah, and sometimes recurrent pregnancy loss might actually be the only clue that a woman has an underlying protein S deficiency. Also, certain acquired conditions like cancer, lupus, severe infections can also lead to reduced protein S levels.
Okay, so that covers the loss of inhibition side pretty well. Losing the brakes.
Right. Antithrombin, protein C, protein S deficiencies.
Now, let's switch to the other side. You mentioned the gain in procoagulant function,
Yeah.
where the body's clotting mechanisms are sort of supercharged.
Exactly. Hitting the gas pedal too hard. This involves conditions where you have increased activity or just higher levels of factors that promote clotting.
And what's the big one here?
By far the most common and one you've probably heard of is Factor V Leiden.
Factor V Leiden. Yes, definitely heard that name. What exactly is going on there?
Okay, so Factor V is a protein that helps speed up the process of making thrombin. It's a procoagulant.
Right.
Normally, activated protein C, one of those breaks we just talked about, comes along and switches off Factor V, helping to keep thrombin production in check.
Okay, puts the brakes on Factor V.
Precisely. But in Factor V Leiden, there's a specific tiny change in the Factor V gene. Just one amino acid swapped for another at a specific spot.
A tiny change.
Seems tiny, but it makes that Factor V protein resistant to being switched off by activated protein C.
So the brake doesn't work on this specific factor.
Exactly. The activated protein C tries to inactivate it, but it just can't do it effectively. So Factor V hangs around longer, keeps promoting thrombin generation. More gas, less brake.
And you said this one is really common.
It is, yeah. It's the most common inherited thrombophilia we know of, especially in people with European ancestry.
How common?
Prevalence is maybe 2% to 7% in the general European descended population, but look at people who've had a VTE, and it can be up to 19%, nearly 1 in 5.
Wow. Is it common in other groups?
Much rarer, very uncommon in people of Asian, African American, or Native American heritage. It's a really striking difference across populations.
Interesting. And what's the risk increase like?
If you inherit one copy of the gene heterozygous, your relative risk of a VTE goes up maybe 3 to 6 times compared to someone without it.
Okay.
If you inherit 2 copies homozygous, that risk can jump significantly, maybe up to 20-fold. But, and this is crucial, many heterozygotes, people with 1 copy, might actually go their whole lives without ever having a clot.
So it's not a guarantee.
Definitely not. It increases the risk, but doesn't guarantee a clot. Often it needs another trigger.
Like what kind of triggers? When do these clots tend to happen?
Typically, VTE related to Factor V Leiden pops up in adulthood, and it's often provoked by something else like a long plane flight, surgery, pregnancy, or using oral contraceptives.
Ah, the oral contraceptive link. You mentioned that risk can vary wildly.
Yeah, the studies show a huge range. For women with Factor V Leiden taking older, second-generation OCs, the reported increased risk of VTE compared to non-users without the mutation ranges from maybe 6-fold up to a staggering 50-fold.
50 times. That's enormous.
It really highlights how these genetic factors interact with environmental triggers.
Hmm.
It's rarely just one thing acting alone.
So, given how common it is, when should someone actually get tested for Factor V Leiden?
Testing isn't usually done routinely. It's more for specific situations where the result might change management. Like someone has an unprovoked VTE and they're thinking about stopping anticoagulants later.
Okay.
Or maybe female relatives of someone with Factor V Leiden are considering starting hormone therapy or getting pregnant. In those cases, knowing might influence decisions. There's a blood test called the APC resistance assay, and then genetic testing can confirm it.
Right. Okay, another gain of function was the prothrombin gene mutation, G2210A.
Yes, that's the one. This mutation isn't in the main coding part of the prothrombin gene, but in a region that regulates it.
So it affects how much prothrombin gets made.
Essentially, yes. The mutation makes the messenger RNA for prothrombin more stable, so the cell ends up producing higher levels of prothrombin protein. More prothrombin means potentially more thrombin generation, again, more gas.
And how common is this mutation?
It's found in maybe 1% to 2% of the general population and perhaps 5% to 10% of VTE patients. It seems to be more frequent in Caucasians, especially those with Southern European or Spanish roots.
What kind of clots does it typically cause, similar to Factor V Leiden?
Mostly VTE, usually in the legs. Arterial thrombosis is pretty rare with just this mutation on its own.
Okay.
An interesting point is that having this mutation alone only slightly increases the risk of a recurrent VTE after stopping blood thinners.
Only slightly.
On its own, yeah. But the risk really shoots up when it's combined with other factors, like women with the mutation who take oral contraceptives have a higher risk of VTE and also clots in the brain veins.
The interaction again.
Exactly. And if someone unlucky enough has both Factor V Leiden and the prothrombin G2210A mutation, their risk of recurrent DVT is substantially higher. Often, those individuals need lifelong anticoagulation.
That really drives home the point about combined risks. Okay, you also listed elevated Factor VIII activity. What's Factor VIII's role?
Factor VIII is another crucial clotting factor. It helps activate Factor X, which is another key step leading to thrombin. Most Factor VIII in our blood is actually bound to von Willebrand factor, which kind of protects it.
Okay, and high levels are inherited.
Well, high Factor VIII levels definitely tend to run in families, but curiously, we haven't pinpointed specific gene mutations that directly cause it yet.
Interesting.
But we do know that having high levels is linked to increased VTE risk. Studies show people whose Factor VIII activity is in the top 10% above the 90th percentile for the lab have about a 4.8 times higher relative risk of VTE.
So is high Factor VIII an independent risk factor then?
It seems to be yes for venous thrombosis. The link with arterial thrombosis is a bit murky
Why is that?
because Factor VIII is also what we call an acute phase reactant.
Meaning
Its levels go up when there's inflammation in the body, like during an infection or other inflammatory conditions. So if someone has an arterial clot and high Factor VIII, it's hard to know if the Factor VIII contributed directly or if it's just reflecting underlying inflammation that caused the clot.
Oh, that complicates things. Makes testing tricky, I bet.
It does. Because levels fluctuate, you ideally want to measure inflammation markers like ESR or CRP at the same time, and you really need to repeat the Factor VIII test maybe twice over time to get a clearer picture. Plus, labs need their own specific ranges for what counts as high.
Gotcha. Okay, moving along the gain of function list.
Yeah.
Hyperhomocystinemia. What's that?
Homocysteine is an amino acid. Hyperhomocystinemia just means having abnormally high levels of it in your blood, usually defined as over 15 micromoles per liter.
And that's linked to clots.
Yes, it's been associated with an increased risk of both arterial and venous thrombosis. There's a common variation in a gene called MTHFR that can predispose people to higher homocysteine levels, especially if they inherit 2 copies of the variant.
How does high homocysteine actually cause clots? What's the mechanism?
It seems to do a few things, none of them good for blood vessels. It can directly damage the endothelial cells lining the vessels.
Oh.
Yeah. It can also make platelets stickier, promote oxidation of LDL cholesterol. The bad cholesterol interfere with thromboembolism, that protein involved in activating protein C, and even increase levels of von Willebrand factor and Factor VIII. So multiple potential pathways.
How common is high homocysteine?
Estimates vary, but maybe 5% to 10% in the general population. But it's much more common in people who already have vascular disease, could be up to 25%.
Is it always a major risk?
There's a rare genetic disease, homocystinuria, with extremely high levels causing early clots. But even moderately elevated levels in adults are linked to a higher risk of heart attack and stroke, maybe 2 to 8 times higher, especially in women. The link to VTE is maybe a bit more debated, but some analyses suggest around a threefold increased chance of a first VTE.
How do you test for it?
Usually a simple blood test measuring fasting serum homocysteine levels, but levels can be affected by other things like vitamin B deficiencies or kidney problems.
So it might need repeat testing.
Yeah, repeating the test is often a good idea. Sometimes MTHFR gene testing might be done too, but the homocysteine level itself is usually the key clinical measure.
Okay, one more in the congenital category.
Yeah.
Dysfibrinogenemia, involving fibrinogen, right?
Exactly. Fibrinogen is the raw material for fibrin, which forms the meshwork of a blood clot. It's absolutely critical. It also plays roles in platelet aggregation and even in breaking down clots later.
So if it's dysfunctional, dysfibrinogenemia, it causes clotting problems.
It can, yes. Paradoxically, while fibrinogen problems often cause bleeding disorders, some specific types can actually lead to a hypercoagulable state, increasing thrombosis risk.
Why would that happen? Less fibrinogen leading to more clots seems backward.
One theory is that if the fibrinogen is abnormal or deficient, it might not bind thrombin properly, leading to more free active thrombin circulating around, which then promotes more clotting.
Ah, okay. And this could be inherited or acquired?
Both. There are hereditary forms caused by mutations in the fibrinogen genes and acquired forms, too. The inherited ones are usually classified as type I quantitative defects, just not enough fibrinogen, or type 2 qualitative defects, enough protein, but it doesn't function right.
What's the clinical picture like?
It's really varied. With the congenital forms, maybe 40% of people have no symptoms at all, about 50% actually present with bleeding problems, and then roughly 10% present with hypercoagulability and thrombosis.
Wow, okay. So the same gene defect can lead to opposite problems.
It's a great example of how complex these systems are.
Absolutely. Okay, we've covered a ton on the congenital side, the genetic factors, but you mentioned acquired causes too, things that develop during life. Let's shift focus there. What are some key acquired conditions that make blood clot more easily?
Right, the acquired causes. A big one and relatively common is antiphospholipid syndrome, or APS.
CPS.
This is an autoimmune condition linked to a higher risk of both arterial and venous clots, plus some specific problems in pregnancy.
Autoimmune. So the body's attacking itself somehow.
Sort of. In APS, the body makes antibodies against certain phospholipid-binding proteins. The key ones we test for are called lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein antibodies.
And these antibodies cause clots. How?
It's complex and not fully worked out, but the thinking is these antibody-protein complexes activate various cells, platelets, monocytes, the endothelial cells lining blood vessels. They might also activate the complement system, another part of the immune response. It creates a pro-inflammatory and prothrombotic environment.
It sounds counterintuitive, but don't some of these antibodies actually make clotting tests longer in the lab?
They do. That's the paradox. Lupus anticoagulant in particular prolongs tests like the ATTT in vitro. But in vivo, in the body, it promotes clotting.
Weird.
Yeah.
How strong is the link between these antibodies and actual clots?
It's pretty strong, especially having lupus anticoagulant or high levels of the IgG type of anticardiolipin antibodies. One major study, the Leiden thrombophilia study, found about a 3.6-fold increased risk for DVT with lupus anticoagulant alone.
But if you have multiple types.
The risk goes up. Same study suggested maybe a 10-fold higher VTE risk if you had lupus anticoagulant plus antibodies against prothrombin or beta-2 glycoprotein I.
What are the clinical signs that might point towards APS?
Well, the main criteria involve having a history of a blood clot, either venous or arterial, or specific pregnancy complications, like recurrent miscarriages or later fetal loss.
Any other clues?
Yeah, sometimes clots happen in unusual places, like veins in the liver or brain. Also, if someone has recurrent clots, they often occur in the same spot. And the risk of recurrence after stopping anticoagulation is quite high in APS.
High recurrence risk, so treatment needs to be long-term.
Often, yes. Indefinite anticoagulation is frequently recommended after a first thrombotic event in someone with APS. There's also a rare but very dangerous form called catastrophic APS, or CFPS, with widespread clotting in multiple organs simultaneously.
How is APS actually diagnosed then? Is it just the antibodies?
There are specific criteria, the Sydney Consensus criteria from 2006. You need at least one clinical criterion, like an unprovoked clot or the pregnancy issues we mentioned, ND, at least one laboratory criterion.
Which are?
The lab criteria are detecting lupus anticoagulant or having moderate to high levels of anticardiolipin antibodies, usually IgG or IgM, or anti-beta-2 glycoprotein antibodies, IgG or IgM. And critically, the positive lab test needs needs to be confirmed on repeat testing at least 12 weeks later
Why the 12-week wait?
to make sure the antibodies are persistent, not just a temporary thing due to an infection or something else.
Makes sense. And treatment. You mentioned long-term anticoagulation. With what?
Traditionally, warfarin, a vitamin K antagonist, has been the mainstay, often aiming for a standard INR target. There's ongoing research into the newer direct oral anticoagulants, the DOACs.
How are they looking for APS?
Mixed results so far. Some studies suggest rivaroxaban might be okay for lower-risk APS patients, like those with only venous clots. But for higher-risk patients, especially those with arterial clots or multiple positive antibodies, warfarin might still be preferred, as some trials showed DOACs might not be as effective or could even be harmful. It's still an evolving area.
Okay, another major acquired cause you brought up earlier was cancer, solid tumors, or blood cancers. Why does cancer increase clot risk so much?
It's really multifactorial. The cancer cells themselves can produce substances like tissue factor that directly trigger clotting.
Ah, the tumor itself driving it.
Yes. Plus, cancer often causes systemic inflammation, which creates a prothrombotic state. Think higher levels of fibrinogen, Factor VIII, more platelets. Then you have factors related to the cancer or its treatment. Maybe the tumor is physically compressing a vein, or the patient needs surgery, or they have a central line for chemo, and chemotherapy itself can increase risk.
Wow, it's a perfect storm of risk factors.
It really can be.
How common are clots in cancer patients? You mentioned a wide range earlier.
Yeah, the reported incidence varies hugely, maybe 1% up to over 40%, depending on the cancer type. The stage risk is much higher with metastatic disease, maybe 20 times higher the treatment being used, and individual patient factors. And honestly, VTE is probably underdiagnosed in this population.
Is there any way to predict who's most at risk? To maybe give preventative treatment?
People have tried to develop tools for that. There are a couple of scoring systems, the Corona score and the Ottawa score. The Corona score is used mostly for patients starting chemotherapy to predict their risk of getting a first VTE, helping decide if they need prophylactic anticoagulation.
What goes into that score?
Things like the type of cancer, some sites like pancreas or stomach, are very high risk: pre-chemo platelet count, hemoglobin level, white blood cell count, and BMI.
And the Ottawa score?
That's more for predicting the risk of VTE recurrence in cancer patients who are already on anticoagulation for a previous clot.
Okay, and how are these cancer-associated clots treated? Is it different?
For a long time, low molecular weight heparin, LMWH, like dalteparin or tinzaparin, was preferred over warfarin. Big trials like Kilo and KET-CH showed LMWH reduced recurrence better.
So injections were the standard.
For many years, yes. Guidelines usually recommended LMWH for at least 3 to 6 months, or potentially longer if the cancer was still active.
What about the newer oral drugs, the DOACs?
They've been studied more recently in cancer patients, too. Several trials comparing DOACs like edoxaban or apixaban directly against LMWH found they were non-inferior, basically, just as good for treating VTE in cancer patients.
So more options now.
Exactly. It offers patients oral alternatives, which can be preferable. The choice depends on individual factors, potential drug interactions with chemo, kidney function, and patient preference.
Right, okay, next on the acquired list. Pregnancy. We touched on this with inherited conditions, but pregnancy itself is a risk factor.
Absolutely. Pregnancy induces a natural prothrombotic state. Hormonal changes lead to higher levels of clotting factors like fibrinogen and Factor VIII.
Okay.
At the same time, levels of natural anticoagulants, particularly protein S, tend to decrease, and the body's ability to break down clots, fibrinolysis, also becomes less active.
So more clotting factors, less anticoagulants, less clot breakdown.
You got it. It all shifts the balance towards clot formation.
Oh.
The overall risk of VTE is about 4 to 6 times higher during pregnancy compared to non-pregnant women of the same age.
And after delivery.
The risk is even higher in the postpartum period, especially after a C-section. And as we mentioned, if a woman has an underlying inherited thrombophilia, her risk during pregnancy is magnified significantly, maybe 8 times higher with AT3, protein C, or S deficiencies.
And you said Factor V Leiden and the Prothrombin mutation are found quite often in pregnant women who get clots.
Yes, particularly in Caucasian women, maybe up to half of those who experience VTE during pregnancy might have one of those underlying conditions.
Given the VTE is a serious cause of maternal death, what's the approach to prevention and management?
It's a major focus. Guidelines recommend assessing all women for VTE risk factors at the start of pregnancy and reassessing throughout. Based on the risk profile, things like personal history of VTE, Known thrombophilia, obesity, immobility prophylactic LMWH might be recommended.
When would prophylaxis be given?
It could be during pregnancy, antepartum, after delivery, postpartum, or sometimes both. For instance, women with a prior unprovoked VTE or high-risk thrombophilia often get prophylactic LMWH for about 6 weeks postpartum. If a clot actually happens during pregnancy, then therapeutic doses of LMWH are used.
Okay, let's talk about oral contraceptives, OCs, and hormone replacement therapy, HRT. Estrogen seems to be the common factor there.
Yes, estrogen is the key player. Whether it's in combined OCs with progestin or used alone in HR2, estrogen is a well-known risk factor for both venous and arterial clots.
Do we know exactly why estrogen increases risk?
The precise mechanisms aren't fully clear, but it seems to affect multiple pathways. It might influence platelet activation, alter levels of coagulation and anticoagulation factors, potentially impair fibrinolysis, and maybe even have some pro-inflammatory effects. It tips the balance towards clotting.
Where do these clots usually happen?
For VTE, the deep veins of the legs are most common. But estrogen use, especially higher doses in older OCs, has also been linked to an increased risk of arterial events like heart attack and stroke, maybe around a 1.6-fold increase, according to some analyses.
Does the risk change over time?
Yes, the VTE risk seems highest in the first few months, maybe the first 4 months, after starting OCs. And encouragingly, the risk usually returns to normal within about 3 months of stopping.
What happens if someone develops a clot while on OCs or HRT? How is it managed?
For an acute VTE in a woman on OCs, standard therapeutic anticoagulation is given, but often for a shorter duration, maybe just 3 months, assuming the OC was the main provocation and there are no other ongoing risks.
Should they stop the hormones?
That's an individual decision based on risks and benefits. There are definitely situations where OCs or HRT are contraindicated, like a personal history of VTE, major surgery coming up, known high-risk thrombophilia, or being over 35 with smoking and other cardiovascular risks for OCs. HRT is generally avoided in women with prior VTE or stroke.
Okay, the last acquired cause on the list was heparin-induced thrombocytopenia, HIT. Specific to heparin use, right?
Exactly. Heparin, both the standard unfractionated heparin, UFH, and low molecular weight heparin, LMWH, is used very commonly, especially in hospitals and around surgery. So HIT is something clinicians, particularly vascular surgeons, always need to keep in mind.
It's an immune reaction, you said.
Yes, it's an immunologic disorder. The body develops IgG antibodies that target a complex formed between heparin and a protein released from platelets called platelet factor IV, PF4.
Heparin PF4 complexes.
Right. These immune complexes then bind back to platelets via specific receptors, FC receptors, and activate them. This activation leads to further platelet aggregation, release of procoagulant particles, and ultimately thrombus formation. It also causes the platelet count to drop. That's the thrombocytopenia part.
So low platelets, but paradoxically more clotting.
Exactly. That's the hallmark of HIT, or more specifically, HITT when thrombosis occurs. It's estimated to happen in maybe 0.3% of vascular surgery patients getting therapeutic heparin. Incidence is generally higher with UFH than LMWH, possibly because UFH forms larger complexes.
One of the clinical clues, how would you suspect HIT?
The main trigger is seeing a drop in platelet count after heparin exposure, usually starting 5 to 14 days after the first dose, though it can happen faster if the patient had heparin recently. The 4T score helps assess probability, thrombocytopenia, how much the count drops, timing, when it drops relative to heparin, thrombosis, presence of new clots, and ruling out other causes for low platelets.
How much does the platelet count typically drop?
Characteristically, it falls by 50% or more from the patient's baseline. The lowest point, the nadir, is usually still above 20,000, so severe spontaneous bleeding is uncommon, unlike in some other causes of low platelets. And venous clots are actually more common than arterial ones, about a 4-to-1 ratio. Unusual things like skin necrosis at heparin injection sites can also occur.
How do you confirm the diagnosis?
2 types of tests. First are immunoassays, like the PF4 heparin ELISA, which detect the antibodies. These are good screening tests, high sensitivity, meaning they usually pick up HIT if it's there, but lower specificity, so false positives can happen.
So if the immunoassay is positive,
Then you ideally need a functional assay for confirmation. These tests, like the serotonin release assay, SRA, or heparin-induced platelet activation, HIPA assay, actually check if the patient's serum causes platelet activation in the presence of heparin. They have high sensitivity and specificity, but are more complex and usually done only in specialized labs.
if HIT is suspected, what's the immediate action? Just stop heparin.
Stopping all heparin is the absolute first step that includes heparin flushes and FIB lines, heparin-coated catheters, everything. But just stopping isn't enough. The risk of thrombosis remains very high, around 50%, even after stopping heparin.
So you need another anticoagulant.
Yes, urgently. You need to start a non-heparin anticoagulant. Options include direct thrombin inhibitors like argatroban or bivalirudin, or fondaparinux, an indirect factor XA inhibitor, or sometimes one of the oral factor XA inhibitors like apixaban.
Anything else?
Because silent DVTs are common in HIT, doing ultrasound surveillance of the legs is often recommended. If a clot is found, it's generally treated as provoked, usually requiring 3 months of anticoagulation, transitioning to warfarin or a DOAC once the platelet count recovers. Since the highest risk period is often in the first 10 days or so after stopping heparin while platelets are recovering, anticoagulation is crucial during that time.
What about using heparin again in the future if someone's had HIT? Is that ever possible?
It's a concern. The antibodies usually disappear over time. Functional assays often become negative within about 50 days, and the antibodies detected by ELISA are often gone by 100 days in most people.
So retesting is key.
Yes. Before considering heparin again, ideally you'd want repeat testing to show both the immunoassay and functional assay are negative. If heparin is absolutely needed urgently for surgery and testing can't be done or is still positive, then alternatives like bivalirudin or argatroban would be used during the procedure.
Okay, we've covered a huge landscape of causes, both inherited and acquired. When a patient actually presents with a blood clot, how do clinicians approach the decision of whether to test for any of these underlying states? Is everyone tested?
That's a really practical and important question. The first step always is a detailed history and physical exam. You're looking for any obvious provoking factors for the clot.
Like surgery, trauma, immobility.
Exactly. Because the truth is, most thrombotic events are multifactorial. The majority of patients won't have one single identifiable thrombophilia as the sole explanation. Arterial clots often have clear links to things like smoking, high blood pressure, diabetes, high cholesterol, and most first-time VTEs are considered provoked by some temporary risk factor.
So if it's clearly provoked, testing isn't usually needed.
Generally, no. Current guidelines don't recommend routine thrombophilia testing for clearly provoked VTEs.
So when is testing considered? Who should be tested?
It's tricky because we don't have perfect guidance from large trials. Recommendations are mostly based on epidemiology and expert consensus. Testing might be considered in certain groups, maybe younger patients, say under 50, with an unprovoked VTE.
Unprovoked meaning no clear trigger.
Right, or someone with VTE who has a very strong family history of clots. Or perhaps recurrent VTEs, especially if unprovoked, also VTE in unusual sites like the veins in the abdomen or brain, or maybe a VTE that occurred with only a weak or transient risk factor.
What about young patients with arterial clots?
Yes, that's another group, arterial thrombosis. In a young person who doesn't have the typical cardiovascular risk factors might warrant consideration for testing, particularly for APS. The fundamental question is always, will finding a thrombophilia actually change the patient's management?
Does it often change the initial management of the clot itself?
Usually not. The treatment for the acute VTE, the anticoagulation needed right away, is generally the same regardless of whether an underlying thrombophilia is found or not.
So where does testing potentially make a difference?
Primarily in decisions about the duration of anticoagulation, especially after an unprovoked VTE.
How so?
Well, if someone has an unprovoked VTE, they're already at higher risk of recurrence. Finding a high-risk thrombophilia like APS or homozygous Factor V Leiden might strengthen the argument for continuing anticoagulation long-term or indefinitely.
But a negative test doesn't mean you stop early.
Not necessarily, no. The decision about duration after an unprovoked VTE is complex, based on the balance of recurrence risk versus bleeding risk for that individual. Thrombophilia status is just one piece of that puzzle.
What about testing family members? If someone has a clot and tests positive for, say, Factor V Leiden, should their siblings or children get tested?
Generally, routine testing of asymptomatic family members isn't recommended by current guidelines.
Why not?
Because finding a thrombophilia in someone who's never had a clot doesn't reliably predict if they will get one, and it doesn't usually lead to starting preventative anticoagulation just based on the test result. The risk associated with long-term anticoagulation often outweighs the potential benefit in someone who's never clotted.
So what should family members do?
They should definitely be made aware of the potential increased familial risk. They should understand the signs and symptoms of VTE and know to seek medical attention promptly if they occur. And they should be particularly cautious and discuss potential thromboprophylaxis with their doctor during high-risk situations like major surgery, pregnancy, or prolonged immobilization.
You mentioned unusual sites like abdominal or brain veins. Testing is more strongly considered there.
Yes, for unprovoked clots in those locations, the likelihood of finding an underlying heritable thrombophilia, especially Factor V Leiden or perhaps APS, might be higher, so testing is often warranted.
And timing of the tests. Does it matter if the person is already on blood thinners for the clot?
Yes, timing is critical for some tests. Testing for the genetic mutations Factor V Leiden and Prothrombin G2210A can be done anytime, even during acute thrombosis or while on anticoagulants, because DNA doesn't change.
What about the others?
Antiphospholipid antibody testing, anticardiolipin, anti-beta-2 GPI can also generally be done accurately while on heparin or warfarin. Lupus anticoagulant testing is a bit trickier, but can often be interpreted during heparin use, though warfarin can interfere. However, tests for the natural anticoagulants antithrombin, protein C, and protein S can be significantly affected by acute clotting and by anticoagulants, especially warfarin.
So when should those be done?
Ideally, testing for AT, PC, and PS should be deferred until a patient has finished their course of anticoagulation and has been off it for several weeks. Sometimes a two-step approach is used. Test for the genetics and APS initially, then test for the others later if indicated after stopping treatment. And importantly, the direct oral anticoagulants, DOACs, can interfere with many coagulation assays, including lupus anticoagulant testing and activity assays for PC and PS, so testing should generally not be done while a patient is actively taking a DOAC.
Okay, so let's say a thrombophilia is found. How does that specifically change the choice of anticoagulant drug or how long it's given?
Perhaps surprisingly, there aren't separate guidelines for anticoagulation based purely on which thrombophilia someone has. The main treatment decisions follow the general VTE guidelines.
So treatment is usually the same regardless.
For the most part, yes. The initial treatment for a VTE event, whether it's provoked or unprovoked, typically involves standard anticoagulation, often starting with a DOAC or LMWH, followed by a DOAC or warfarin.
For how long?
For a provoked VTE, usually 3 months is sufficient. For an unprovoked VTE, as we discussed, extended or indefinite therapy is often recommended to reduce recurrence risk, unless bleeding risk is too high.
And that's where the thrombophilia result might weigh in.
Exactly. In the unprovoked setting, finding a high-risk thrombophilia might tilt the balance more strongly towards recommending indefinite anticoagulation, but it's still an individualized decision.
Are there any exceptions, like for cancer patients or APS?
Yes. For cancer-associated thrombosis, LMWH or certain DOACs are generally preferred initially, as we discussed. For APS, particularly high-risk APS, warfarin is often still considered the standard for long-term therapy, although DOACs are being used more in lower-risk cases. And if someone has a clot while already appropriately anticoagulated, say, a recurrent VTE on warfarin or a DOAC, then switching to LMWH, perhaps at a higher dose, is often recommended.
This has been incredibly thorough, really breaking down a complex topic. To try and tie it all together, what are the absolute key takeaways for our listeners?
I think the main things are hypercoagulable states, these thrombophilias, they can be inherited or acquired. They definitely increase your underlying risk of blood clots. Understanding the specific type can be useful for context, maybe for family implications or understanding the mechanism.
Right.
But crucially, the actual treatment for a blood clot event often follows general guidelines focusing on effective anticoagulation tailored to the individual's overall risk profile. And the decision to even test for thrombophilia isn't automatic. It really depends on specific clinical situations where the result is likely to genuinely influence management decisions, particularly around the duration of therapy.
That's a great summary. And as we wrap up this deep dive, here's something to think about. We've talked a lot about the mix of genetics and environment in these conditions. So looking ahead, how might personalized medicine evolve to better pinpoint individuals who are at high risk before they ever have that first dangerous clot? Could we develop strategies to manage that risk proactively, based on a combination of genetic markers, lifestyle factors, and maybe even ongoing biomarkers? It's a really exciting area for the future.
Definitely food for thought.
Absolutely. And of course, if any of this discussion has raised questions about your own health or family history, the best step is always to chat with your doctor or healthcare provider.